I would like to thank the organizer for inviting me to give a talk on anti-GD2 immunotherapy, neuroblastoma, and beyond. The first monoclonal antibody ever approved for cancer therapy is rituximab in 1997. Since then, there are hundreds of monoclonal antibodies on the market for cancer treatment. However, if we examine the antigen target, the number is actually quite limited, as shown in this slide here and next slide. Altogether, there are only 22 targets with monoclonal antibody approved for cancer treatment. All of them, except GD2, shown in red here, are protein antigens. Those in green refer to immune checkpoint molecules. In fact, glycan associated with cancer are often abnormal. The approval of GD2, a glycolipid, suggests that many of these glycoproteins or glycolipid may serve as ideal antigens for the immunotherapy. The development of anti-GD2 started in early 1980s when I started to collaborate with Dr. Ralph Reichfeld at Scripps Research Institute. We immunized some mice with neuroblastoma cells and generated a monoclonal antibody that stained very strongly with neuroblastoma cells, but not the interstitial normal stroma. Subsequently, Steve Gillis humanized the antibody by combining the mouse variable gene with a human IgG1 constant region. As it turns out, anti-GD2 also react with glioma, melanoma, small cell lung cancer, and a variety of sarcomas. So its clinical application will not be limited to neuroblastoma. The development of anti-GD2 took a long time because of its orphan disease. I filed IND for chimeric antibody in 1989, which is the very first chimeric antibody ever filed for IND. Although the phase 1 clinical trial and pilot study combining CH1418 with GM-CSF went smoothly and confirmed that by POG phase 2 trial, we ran out of supply. But let me first share with you our initial success with one case. This is a 4-year-old with stage 4 neuroblastoma from Tennessee who has persistent bone marrow metastatic lesion and could not undergo stem cell transplant. After a few courses of chimeric antibody with GM-CSF, his marrow disease cleared up completely, and he remained in long-term remission to be a very healthy young adult these days. And because of him, we also got recognized by San Diego baseball team, San Diego Padre, which provided us $100,000 of research support each year since then. So the large quantity needed for phase 3 study was provided by NCI because industry was not interested in the orphan disease. So the phase 3 trial was designed for high-risk neuroblastoma risk patient to receive standard of care with upfront chemotherapy, surgery, stem cell transplant, radiation, and then randomized to standard of care with 13-cis-retinol acid or plus immunotherapy. Immunotherapy consists of 5 courses of CH1418, and in course 135, GM-CSF was given. Course 2 and 4, IL-2 was prescribed. Here is the outcome of the 226 randomized patient. The standard arm patient showed a 2-year event-free survival of 46%. Immunotherapy group, 66%. This 20% difference is statistically highly significant. Similarly, there is a significant improvement in the overall survival. This was subsequently published in New England Journal of Medicine. And this data served as the base for subsequent FDA approval of chimeric antibody in March of 2015, followed by European Commission approval in August of that year. So this is the very first successful immunotherapeutic agent targeting a non-protein antigen. And in 2017, the European Commission approved another similar product called dinutuximab beta, since it's the same CH1418 but produced in CHO cell instead of mouse hybridoma cells. The European study used this dinutuximab beta to randomize patients without IL-2. And the results showed that there's no difference in EFS or overall survival. So the addition of IL-2 did not further improve in the survival, but IL-2 did contribute to greater toxicities. Now, is GM-CSF necessary? There is no randomized study, but one can look at Nikon Chong's group. They reported sequential studies comparing old studies without GM-CSF and later study with GM-CSF. As you can see, with the addition of GM-CSF, there is a better progression-free survival and overall survival. But like I say, this has yet to be confirmed by a randomized trial of anti-TB2 plus minus GM-CSF. So the current status is to say that that GM-CSF may provide some benefit. Now, data from the COG study by Sandell's group indicate that soluble IL-2 receptor are increased after GM-CSF courses. So you may not need IL-2 infusion to get the benefit of IL-2 activation. So the current COG guideline for post-consolidation therapy is to remove IL-2 from course 2 and 4, but instead give GM-CSF for all 5 cycles of immunotherapy. And here is the long-term follow-up of the COG study. It's a median follow-up of 10 years. Again, The immunotherapy showed better event-free survival, significantly at a p-value of 0.042. But you will notice that the difference has narrowed. The same is true for overall survival. So the relapse event-free survival curve suggests that with immunotherapy group, late relapses occurring after the initial 2 years contributed to the smaller difference between the two groups. So what can we do to improve the efficacy of dinutuximab and at the same time reduce the well-known anti-GD2 infused toxicity, especially neuropathic pain? First of all, COG conducted a phase 2 study combining chimeric 1418 with chemotherapy in the relapsed neuroblastoma. Patients received a backbone chemotherapy of irinotecan and temozolomide. They are randomized to have ALAM mTOR inhibitor, temozolomide, or anti-GD2. In the initial 35 patient randomized, one can see a clear difference between the two groups in the response rate. So the chemoimmunotherapy is clearly better. So the randomization was terminated. And this study continued to accrue patients on chemoimmunotherapy arm. Altogether, 53 patients received this combination, with 41.5% responded. Some of these are durable responses. With that data, COG conducted a pilot study combining anti-GD2 with upfront chemotherapy. So this pilot study has completed accrual. We are in the process of analyzing the data. Another strategy is to further improve chimeric antibody efficacy by changing into humanized antibody. And so there is a product, Q1418 or 3F8 by Nikon's group, humanized into naxitamab. In our lab, we have shown that the Q1418 is a mutation, a 322 amino acid residue can reduce CDC but did not affect ADCC. Since CDC is known to be crucial for the neuropathic pain, this mutant antibody may produce less neuropathic pain. Indeed, in the rat model, we can poke the rat paw with mechanical pressure and measure the sensitivity to this allodynia. As indeed, with the chimeric 1418, the pain score is quite high, but the humanized antibody is significantly reduced. And a phase 1 study at St. Jude Children's Hospital showed that this humanized mutant antibody indeed has a greater NTD, about 3 times greater than the chimeric antibody. Using this data, Dr. Furman conducted a pilot study combining the humanized antibody with induction chemotherapy, cytoxan, and topotecan. It was well tolerated, and 80% responded with better than PR. This is much better compared to historical control of 40%. On the other hand, humanized CF8 also show very nice safety data and efficacy in relapse patients. So it received FDA approval for treatment of relapsed neuroblastoma late last year. Another strategy to improve chimeric antibodies efficacy is by combining with immune modulator, lenalidomide. It's a relative of thalidomide. It can increase GM-CSF, IL-2, IL-15 level, increase number of NK cells and NKT cells. In a NAN study, combination of lenalidomide with CH1418 and isotretinoin showed that the NTD is well tolerated, 100 milligram per meter squared, and there are clinical responses with 71% having stable disease or better. One other strategy is to combine chimeric antibody with DFMO. It's an old drug used for treatment of African sleeping sickness. It is a potent inhibitor of ornithine decarboxylase, which is a key enzyme for synthesis of polyamines. We also know that polyamines are essential for cancer cell survival and neuronal cell function. So it may have dual effect of increase the anti-cancer efficacy and also reduce the neuropathic pain. Indeed, the anti-GD2 in combination with DFMO showed less allodynia in rat model. And in the GD2 positive tumor model, combination of DFMO and anti-GD2 showed significantly improved survival. And the NANT has completed the phase 1 study combining DFMO with topotecan and cyclophosphamide. Currently, COG is planning a phase 3 randomized study of anti-GD2 plus minus DFMO. One last strategy I would introduce is to target O-acetyl-GD2. O-acetyl-GD2 stains very strongly neuroblastoma cells, like 14G, the initial anti-GD2. However, it does not cross-react with peripheral nerve fiber, unlike the original anti-GD2. In animal studies, the anti-GD2 and anti-O-acetyl-GD2 showed very good anti-tumor efficacy. So this is in preclinical development. Hopefully, it will soon become available for clinical trial. Lastly, I'd like to thank all the players that is important for the development of dinutuximab. First, Ralph Reisfeld is Scripps Clinic, who just passed away 2 months ago. UCSD and NCI support for making kilogram of CH1418. COG, NCI grant support, and Padres Foundation, United Therapeutics, and FDA. Last but not least, the neuroblastoma patient and the family.